Right. So today I am going to be talking about how we use service design to architect an oncology experience. First up, a little bit about Mad Pow. We are a strategic design company based out of New England. And we use the psychology of motivation to create innovative experiences. And these could sometimes be digital solutions, but sometimes it could be the real world spaces as well. But our focus is on making solutions that are good for people as well as for business. So today I'll tell you a little bit about a project that we did where researchers and strategists were closely embedded with staff at a cancer center and the contracted architects to truly understand the use of space by patients, caregivers, and medical staff. This is a project close to my heart, so I'm very happy to be talking about it today. We started by collecting information about the different people that move through these spaces using multiple research methods, such as one-on-one interviews with oncologists, nurses, the admin staff, patients, caregivers, and in this context, I mean caregivers to be family members or friends, anyone who supports the patient in their health. We also went on site and observed the spaces and people interacting with them, and eventually used participatory design methods to ideate on what the users of these space envisioned the future to be. If anyone is unfamiliar, participatory design is an approach that invites users into the actual process of design. Especially generative activities provide people with tools to express themselves, especially if they're non-designers. And they use these tools to express how they want that future to look like for them. If you'd like to learn more about this topic, I recommend you read some of Liz Sanders' work on participatory design. So we first started by having the staff, clinical and non-clinical, go to other cancer centers, observe what the spaces looked like, and bring back that information to us. And together we looked at these pictures and talked about what feelings, what principles, what qualities these spaces emanated. And as you can see over here, this is us putting all those thoughts over here, and we saw things like comfort, state-of-the-art, healing, community, display things that clearly indicated what was important to the staff that we were working with. And then we invited the oncologists, nurses, patients, and caregivers to work together in a room to design individual spaces. And we asked them to choose the space that they spent most time in. Because of the one-on-one interviews, we had a rough idea of what these spaces were and what goes into these spaces typically. So knowing that we were working with a non-design audience, we equipped them with these cutouts that you see over here that they could then just pick and put into different places, arrange things as they wanted. So I'll share a few examples here. First up is the provider offices and the exam room. So these were diagrams that were made by doctors themselves. You see here the proximity of the exam room and the provider's office that was expressed again and again, as well as specific needs from the exam room, such as having enough space for caregivers to sit when they accompany patients on their visit. Windows were a big theme as well, as you can see in both these images. A lot of people decided to show waiting areas and redesign the waiting areas, indicating that they spend a large amount of their time waiting. They had elements such as couches, fireplaces, rugs that they added in there, which indicated that they hoped that these spaces would be comfortable for them and inviting for them, since they spent such a large amount of time here. And then also had them work on infusion rooms. Sunshine was a big theme of the overall research. On the left, you see people talked about having enough space for themselves, which is the big pom-pom. and the person that is accompanying them, that is the small pom-pom. Similarly, we had people do many other spaces, and they chose which spaces that they worked on. There's more where these came from, but these are just some examples. Moving on from individual spaces, we had people think about the larger journey that patients go through. We looked at it from 4 different lenses. Medical oncology, that I'll talk about as med-onc. This is when infusion or chemotherapy is used as a form of treatment. And radiation oncology, that I'll talk about as rad-onc, where radiation is used as a form of treatment. And we realized that the experience looks very different for new patients and those that have been diagnosed and are just coming in for a visit. So we built a deep understanding together with staff and the patients on what this journey looks like. By understanding the journey, this gave us food for thought of thinking about the space and the layout of this new cancer center that would come up in a few years. You see here staff and patients interacting together to talk about how they would move through these spaces, what they need from these spaces, and describing the layout as well as the needs as they went along. I'll share a couple of examples with you. So med-onc, this is the new patient journey as it relates to the space. So at the bottom, you see over there, valet. So having a convenient way to park was a very important theme. Having a reception where people would have to check in just once and get directions on where to go. 3, when they would come up to the med-onc department, they would be welcomed and don't need to check in again. 4, having the physician office next to the exam room, as we talked about earlier. So this is where the PA or the nurse takes the patient's vitals and then gets the physician to come in for the actual visit. Staff downtime was a big theme of the research as well. 5, you see that physicians express the need to have their support staff in close proximity to them. Also on the left, you see a space for education and support services. This was very important for those that had been newly diagnosed, as they needed to learn a lot very quickly. And 6, you see where patients, especially new patients, would go through things like finances, how do I get additional support, etc. So very quickly, this is typically what a new patient journey looks like as it is expressed in the lens of the space itself. Similarly, we had med-onc. I'm calling it frequent, but by this we mean people that have been diagnosed and are coming in for the infusion or chemotherapy. At the bottom, you see 1, which says there is the reception area. Again, an important theme to have a nice reception where people just check in once. For infusion, people need to get labs done within a few hours of their therapy. So having an on-site lab where they would get their blood drawn, as well as get access to their ports for people that have ports implanted for chemotherapy. And then on the right, you see 3, where after the lab, patient goes to the exam room, and they can visit with the doctor, visit any support services such as a nurse navigator, social work educator. And then 5, they go into the infusion bay and get their treatment. That's where they spend a majority of their time. I'll move on. So these are just some examples of the spaces. But overall, the research yielded these 10 principles that we collaboratively aligned on. These were principles that we agreed we wanted to build on and look back on when building out design solutions for the Cancer Institute. I'll talk about a couple of principles and how they manifested in recommendations for the space itself. A cancer diagnosis is a difficult time for anyone, and there is a lot of uncertainty and a feeling of loss of control at this point. So anything that reinstills that sense of control and empowerment would create a much better experience for people with cancer, as well as their families. The ways these manifested was having spaces that were not confined to the waiting area, where people could spend the time that they spent waiting for labs or to see their doctor or any other reason. And to provide that flexibility, pagers can be a good way to be able to facilitate that. Another example is something we heard, that a lot of people spend a significant amount of time at the cancer center. And that transition of home work to the cancer center seemed a little stark. So potential implications of this could be having a person that would greet people coming in, reduce confusion, some of the uncertainty felt by people, as well as this sense of fear that might come with a cancer visit. So this greeter would also perform functions such as checking the person in, checking the insurance, etc. Other ways this would manifest in the space is using furniture and design that is reflective of a home, while at the same time balancing it out with the state-of-the-art care that is expected of a cancer institute. So these are just some examples of how the principles yielded potential implications for the space. But I'll dive a little bit deeper into what we did with this information. So at this point, we had now amassed a deep well of knowledge about the cancer experience at this particular center, as experienced by patients, caregivers, as well as the providers. And we needed a way to bridge our disciplines between us and the architects that we were working with. Before we dive into what we did, I want to talk quickly about on-stage, off-stage model, because I'm going to talk, this is going to be part of the diagrams that I'm going to show you. The on-stage, off-stage model is a model for designing health spaces, which creates shorter waiting times for patients and more collaboration opportunities for the care team. So this in turn really increases the amount of time a caregiver can spend with a patient and creates an overall better experience. So on stage, as the name suggests, are places where spaces where patients and family members primarily spend their time. So places like waiting rooms, exam rooms, labs, and other patient care areas. And offstage is any space that is behind the scenes, meant for care team to collaborate on, have breaks in their offices, etc. So these are just two concepts to keep in mind. So to be able to bridge that understanding that I just talked about, we created these conceptual diagrams to translate that experience principles that we just talked about to the redesigned space. Now, these are not architectural diagrams. They will probably not be to scale as well, so please forgive that. So I'll start with a few elements. I talked a lot about the greeter that would help help the transition between life and the cancer center. So it was largely decided that the north entrance that you see up here would be used as the cancer visit entrance. And the greeter here would help the patient with their visit and direct them. However, for new patients, it would be quite likely that they would not have that knowledge and walk in from the south entrance. So here, that this person would also be trained to direct them appropriately. And where they would send them is up to the second floor, where there is a secondary greeter right next to the elevator. This person, their role would be for the patients that have checked in, reassuring them that we know you're here and someone's going to get you shortly, as well as check in any patients that have not checked in already. They would also play a teaching role in orienting new patients and setting expectations for future visits. So things like, this is where the lab is, this is the cafeteria, you can wait here next time, you don't need to check in with me next time, etc. Other things of note on this floor is the lab that I talked about, which is where patients need to get their labs done prior to chemotherapy. Labs can take anywhere between 20 minutes and 2 hours, and how that played into the overall experience is that, firstly, for shorter wait times, patients would come in from either one of the entrances, have their labs drawn, and then walk up to the second floor for the visit with their provider or to have their infusion. This follows the Disney model of creating an activity while waiting, thus thereby making the process of waiting less tedious. And for longer wait times, patients could utilize the cafe and the waiting area, which is a nicer space than the one there is on the second floor. So this uses the same principles that some airports have, where they have amenities and a larger waiting area at the central location, while there are fewer amenities at the gates themselves. This would also provide the flexibility of waiting at a slightly social place or the more private place, which is on the second floor. I talked earlier about the pager that would give people more flexibility about what they're willing, about where they want to spend their time while waiting. So that was critical to ensuring that this flow through the space would hold. And then lastly, on the first floor, there'd also be the people that would just come in, not have labs for the day, and come right up to the second floor. So by translating those journeys into the spaces, we were able to ensure that there are minimum turns, minimum confusion about where people need to go, and the spaces themselves are aligned with the experienced journey. I'll also talk about another example. So this is related to Med Onc specifically. This is the exam space, which is up on the second floor. So the secondary greeter that I talked about would be in this general area, if you can envision that. The recommendations here were making clear distinctions between offstage and onstage circulation to allow private space and uninterrupted communication for staff, including downtime for staff. That was a big theme of the research. Another thing we heard, and as several of you may already know, that provider mental health is a very important conversation in America right now. Providers expressed that having more natural light would help them feel better about their day because they spent a majority of their time indoors. So we made recommendations on designing to share the natural light among staff instead of just keeping it to those that have offices along the walls. This also creates little nooks that can be used flexibly, either for medical assistance. If you remember, we talked earlier about providers wanting their support staff in close proximity. This could also be used as quiet private spaces or touchdown spaces for any providers visiting from other centers. There is a small collab or touchdown room between the office and the exam room. And this is because providers would like to consult with their support staff before entering the room, learn about the vitals of the patient, discuss the patient history, etc., before entering the exam room. So provider would go from their office here to the collab touchdown space and into the exam room, as you see over here. The exam room, so this is a row of exam rooms here. To be able to facilitate this on circulation and off circulation, so on stage and off stage experience, they would need to have dual entrances, with the off stage entrance only accessible via a key card entry so that patients don't accidentally walk in there. So the orange line over here is where patients would walk in. This is the waiting area. They would walk in, have their visits for the day, and then walk out that way. And the gray lines that you see here is staff only. And then we also had education and social workers rooms centrally placed here and very close to the exam rooms. If you remember, this is especially important for new patients if they've received a new diagnosis and need to have a more detailed conversation on their care going forward. And then lastly, we heard about the places for staff to unwind. So we recommended a staff-only lounge, which is accessible only via the off-circulation areas. And there would be a large garden here, but one portion of the garden would be cordoned off and made staff only, so they have a little bit of that downtime. We heard consistently that while walking through common spaces, staff was often stopped. Providers, especially doctors, were stopped by patients who had questions for them or just wanted to say hi. While some providers liked that, for other providers, this was their downtime that they really needed to keep up their energy for the day. So those were some examples. So going forward, what was done with this work? The shared understanding we heard from the client that we built was invaluable to the center, not just as it relates to the space design, but as it relates to having cross-understanding of how the two departments, MedOnc and RadOnc, work together, as well as how the staff within those departments work together. The desired characteristics of individual spaces, some examples of which I showed you earlier, the waiting rooms, the exam room, etc., were incorporated into the design by the architects. This project was part of a larger service design effort where we also explored the wider ecosystem of cancer care, and there were many opportunities there that yielded action. And lastly, unfortunately, the recommendations on the layout of the space that I just walked you through were not fully incorporated into the final designs. I am out of time, but if you have any questions about why that was, I am happy to share more. All right, thank you, everyone. I look forward to taking some of your questions. And if you like, you're welcome to add me on LinkedIn to continue the conversation.
Perfect. Thank you so much. I appreciate that. So I think I'm going to ask the question, why the hell was it not implemented?
Several reasons. Firstly, organizational dynamics, as well as dynamics with the architects. We are not experts on architecture. We didn't want to position ourselves as experts on architecture. We wanted to show how the experienced journey can fit into architecture, and it was not received well by this particular firm that we worked with. Secondly, the center itself had organizational dynamics that led to a stall in the redesign of the cancer center. I don't know where that is right now, but these were two reasons they weren't fully incorporated.
That's quite interesting because my sister-in-law is a doctor up in Cornwall in the UK, and we were just talking about service design in the hospitals, and she says that their layout makes zero sense, in the sense that from where they do the blood test to where they test it, they have to walk through the whole hospital. So surely architectural firms, especially when you're designing hospitals, should be thinking about service design. Is that not sort of a standard practice, or they kind of sort of just put a building next to I don't know.
Since I did this project, I've kept an eye out of what's happening in this space because, as I mentioned, this project is very close to my heart. Yeah. And thinking about the reason I work in healthcare is because I want to make it better. I experience healthcare often in the US, and it is not the best system. I have been keeping an eye out on other firms and met other designers that are architects by training and have also been trained in human-centered design that are bridging this gap that we were not able to bridge. The other thing I forgot to mention is architects start with this place of what they call a program, which is a certain number of rooms, that a certain number of infusion chairs that they are hired to make. So they absolutely must make those many chairs because it relates to revenue for the hospital. I think due to the layout, especially the recommendations we made on staff well-being, encroached on, I think, 2 infusion chairs, and that was a big discussion point as well.
Wow.
Yes.
Wow. That was a very good talk. Thank you so much for that. I think it's something that I'm very interested in, and I speak to someone who presented, Dr. Giles Morrison, this morning about that quite often, in the sense that I mean, I look at just the layouts at hospitals, but it kind of makes sense in the sense that if it's not generating revenue, that's where they're coming from, isn't it? Really, the bottom line.
Partly, yes. And this is something that I constantly try to talk to clients about, especially in healthcare. I don't know if this came up earlier in conversation, but the rate of suicide amongst the providers is abysmal. It should not be happening. So anything, I believe, that can be done to better the provider experience will inevitably lead to a better patient experience. So that is an important aspect of healthcare that is often overlooked.
Okay. I think Michael just made a comment. I don't know if you can see the chat section there. Yeah. Rian just made a point as well, which is very right. The fight between long use spaces and the right after construction due to huge upfront costs. I think that's something to consider as well.
Yes. I am hoping, though, I'd like to continue talking about this work that we did. And we do have other people that when we talk about the way we incorporated a human-centered understanding to the space, they get very excited about it. And it's clear that there is a need in healthcare to be thinking about these things. As we expect our digital interfaces to be intuitive, we expect our real-life interactions to be intuitive as well. The expectations are shifting from healthcare massively, and this is going to translate to the space as well very soon. So this is something that I hope everyone continues to think about.
Okay. Super, Priyama. Thank you so much. Appreciate your talk. Very insightful, very good.